So we wish to thank Dr. Patrick Arbour, again, founder of the Friendship Line and the Center for Elderly Suicide Prevention, both projects at Institute on Aging. Dr. Arbour conducts workshops and presents lectures both locally and nationally, and he's the author of numerous articles and book chapters on a variety of aging-related topics. He's also been a senior lecturer at Notre Dame de Namur University in Belmont, California, an occasional lecturer in the School of Social Welfare at the University of California, Berkeley, and an adjunct faculty member at the Wright Institute. He's the recipient of several awards, including the 2013 Mental Health and Aging Award, presented by the American Society on Aging, a silver medalist for public service, sponsored by the Jefferson Award Regional Committee, and the 2016 Norma Satin Community Service Innovation Award for his ongoing commitment to human rights and community living. And without any further introduction, I will turn it over to you, Patrick.
Thank you very much, Catlin, for that kind introduction. And I just wanted to welcome everyone, as Catlin has said, and especially want to recognize our Friendship Line volunteers. I think many of them might be on this Zoom training this morning, but also people who may be in the role of peer counselors. I welcome them, our social workers and MFTs and care providers, service coordinators, any of you who have been working in your career in the field of aging. And I am very glad you're here. And the title of this program today is When a Client Isn't Suicidal but Doesn't Want to Live. And, as Catlin said, I've been doing this work for many years with the beginning of the Friendship Line, which started in 1973. And I had to smile to myself when Catlin said that she was not on camera, but I'm on camera. And as you can see, I'm older and I don't mind that at all. And I'm glad that I am still here with everybody. And I find that in an ageist culture, I really believe that it's important for us in the field of aging to be able to acknowledge, where we are on the age continuum. And I'm 73, I'll be 74 this year. And I don't say that with hesitation or regret or shame or whatever. That's how old I am. And 73 is not the new 53. 70 is not the new 50. 80 is not the new 60. And what I really try to say to people, especially those of us who work in human services, especially with older adults, is that, we need to be able to let people know that aging doesn't have to be feared. I think aging has to be respected. But again, in an ageist society, it's very difficult to allow yourself to experience growing older because there's so much negative connotation around just the word old. So as kind of a foundation, I wanted to just open with just some comments about, why focus on adults and especially on older adults when it comes to suicide prevention. And what we know, and we've known for quite a few years now, over a decade, that the most rapidly growing segment of our population are those people 85 years of age and older. And the second fastest growing age category in America today is the 100 plus. And so I'm sure that, most of you, or probably all of you, have said to yourselves at times or to your loved ones that you want to live, as long as you can. You want to, have a good long life. We often hear that phrase. And then when I say to people, that at least statistically speaking, we really could achieve that. The possibility of, most of us, on this Zoom meeting, will be able to live, well into our 80s or 90s or hundreds. I just had a relative of mine die early this morning, at the age of 96. And it was only in the last probably 6 months that her health really declined. And she had been then admitted to a hospice where she died early this morning. And she was my aunt. And so I'm just kind of thinking about her as we go through this training. And so what we want to be aware of is that the numbers of older people that are going to be, contributing, to our society in whatever ways they do. I just think it's important to recognize them. We had an older volunteer, her name was Ebby, and Ebby Bassi, and she died a number of years ago. But what she had always said, and we gave an award in her honor every year for quite a long time, was that she said every age, has its contributions to make. And older people, just as younger people, can contribute. The difficulty is because of ageist attitudes, we often sideline older people and don't value what they could contribute. And that can lead them to have, low morale or feelings of hopelessness or powerlessness or uselessness. And we just want to think about that. And I also urge us all to, think about your own age right now, your own chronological age, and just be aware of when you say 36 or say you're 72 or 80, whatever, just be aware of what feelings kind of get aroused as you acknowledge your chronological age. Catlin was kind enough to acknowledge what Friendship Line is about. And and since 1973, the pillar of Friendship Line was loneliness, social isolation, and prevention, which we believe is so crucial. What we've always believed in at Friendship Line is trying to help reduce the likelihood that an older person would be in a suicidal crisis. And oftentimes here at Friendship Line, because we do get those kinds of calls, they're certainly not in the majority of our calls, but we do get those occasionally. And they're often the easier type of call to deal with, because if there's an imminent risk of suicide, that's requires a 911, and it's pretty straightforward. But the problem, as we will be discussing, is in the title, which is, when someone isn't overtly suicidal, but they are contemplating suicidal thoughts. And that's a challenge for us. And we'll be talking about that more as we go along. Friendship Line staff or trained volunteers do make outreach calls. You can call IOA Connect if you have somebody that you would like us to reach out to. And then we also have our traumatic loss grief groups that are on the Zoom platform since March 2020. We've been holding those groups. We used to have them, we used to have a Saturday morning drop-in group here at Institute on Aging, but since the pandemic, we've been doing them online. And from what I gather from our participants who join those groups, they really are hoping that we continue to do the Zoom platform, because it's just so much more convenient for a lot of people. And a lot of older people are very hesitant to ride Muni these days. And so they really are grateful that they have this other option. And you can always email me if you want to refer someone to a Saturday morning drop-in grief group, which would be fine. And so we're looking at a number of concepts. And first, we want to acknowledge, death by suicide. And this is when people direct violence at themselves with the intent. There's a desire and intention to end their lives, and they die because of their actions. So suicide death occurs because someone took some action against themselves. And the majority of people who die in the United States by suicide death, the most frequent method is firearms. And as I was saying this, I just wanted to acknowledge that for those of you that have had a loss of a loved one, a family member, a friend, a classmate, a colleague, to suicide death, I just want to empathize with you about that. And I would imagine, just as I'm feeling this, because I've lost people to suicide death as well. And I always feel a shift in my energy when I acknowledge death by suicide. And so I just want to say that to all of you, that if you've had a loss of a loved one to suicide, it can be a very challenging bereavement experience for you. And it's best when we talk about death by suicide to avoid terms such as, my loved one committed suicide, or my loved one successfully completed the act of suicide. When referring to death by suicide, these terms often carry negative connotations. So what we tend to want to acknowledge is that a person dies as a result of suicide, but we don't want to acknowledge death by suicide by saying it's successful, the person died by committing suicide. So we'd prefer not to use that. And but parasuicide is the term that often comes up when a person isn't overtly wanting to die by suicide. And parasuicide is also kind of challenging to define. And it's very difficult to find research studies that look at parasuicide among older people. There's a dearth of empirical evidence about how older people relate to this particular concept. And historically, there has been much controversy surrounding the definition and conceptualization of parasuicide. Also controversy around suicide and other suicide spectrum phenomena. And so there's not a lot of research studies that really look at parasuicide and how that relates to an older population. There is a researcher, his name is J.M.G. Williams, and he provided a operational definition of parasuicidal behavior that I think covers a lot of territory in a short sentence. And he called it any non-fatal, serious, deliberate self-harm with or without suicide intent. And that's where the tricky part of this is, that someone who is parasuicidal may unfortunately do a behavior that might be a cry for help, but they wind up dying by that particular method. So parasuicide is very closely related to suicide, but what we want to think about is intent. What we want to think about is the desire. Does the individual really desire to die? It's kind of like the dead is dead theory, that, if you do a dangerous behavior, even if it's meant to be a cry for help, the outcome might be death. And so we want to be thoughtful about that. Passive suicide is another term that we often hear people say that my loved one, really doesn't want to die, but they wouldn't mind if they got hit by a bus as they crossed the street. And passive suicide, the definition would be ambiguous behavior that tends to be self-destructive, but not actively so, and is sometimes thought to reflect suicidal intentions. And examples of this behavior include, failing to feed oneself or to take your medications or go to your dialysis appointment or to engage in rudimentary self-care. And the World Health Organization chimes in with a definition of suicide attempt, which is a potentially self-injurious behavior that is associated with at least some intent to die as a result of an action taken. So again, another term, suicidal ideation, thinking about suicide. And this is usually defined as passive thoughts about wanting to be dead or active thoughts about killing oneself, not accompanied by planning the suicidal behavior. So people can think of suicide, and I would imagine that there are those of you on this Zoom training today who at some point in your life, when you were going through maybe a difficult time, or you didn't get into the school that you had applied to, or you didn't get the job you wanted, or a divorce, or whatever it might be, the loss of a loved one, that you may have thought to yourself, why go on? How can I manage this life when I've had these major disappointments? And so thinking about suicide again doesn't mean that the person is going to actually complete the act of suicide death. But there's something in there that we really want to be aware of, and we want to be able to kind of explore collaboratively with the person who might say to you, I just don't want to be here. And so we want to, contemplate that. Again, why focus on older people? As I said, because just the population of older people is aging, in a very steady growth pattern. Also, we know that older people for decades have one of the highest rates of suicide among any other age populations until 2007, 2008, with the Great Recession. Middle-aged, mostly white men between the ages of 45 and 64 had a huge spike in their rates of suicide, and that sadly has been continuing. And with the pandemic and the unemployment rates being so high, and people not being able to pay their rent or pay their mortgages, and just all of that stress, plus the over 600,000 or more people who have died as a result of COVID, and just the overall stress and strain and loneliness, I'm very concerned about what 2020 and what 2021 will reveal about death by suicide, not only here in the Bay Area, but across the country. Also, with later life, suicide action tends to be more lethal among older men and older women. Baby boomers and later cohorts tend to have higher rates of suicide. And so we want to pay attention to, people like myself who am in the 70 to 80 corridor. And one of the problems with this, and this is what Thomas More talks about in his book, The Aging Soul, is that, we can say to ourselves in our 60 to 70 corridor, age corridor, that we can still say we're middle-aged, keeping in mind that to be old is something to be really is very threatening to a lot of people. And but I'm heading into my middle 70s, and to say that I'm upper middle age would not be truthful. And that what Thomas More said, we know what is coming at the end of the 70 to 80 age corridor is older age, that 80 is not, again, the new 60, it's 80. And we just need to be aware of that, and we need to talk about it, and we need to help older people that may be, internalizing ageist attitudes about themselves, to talk about that. It's very important to do that. And we want to also recognize older people that have, chronic health issues that might be, heart related or, things of that nature. Could be, diabetes, it could be, cancer, it could be leukemia, it could be other kinds of issues. So we really want to help them, help them find a way to manage the movement into older age. The other thing about older people that we want to keep in mind is that they, as a population, they tend to be a little more frail, or they tend to be isolated. And we know that loneliness plays a role. It can be, accompanied by a depression or anxiety. And we've certainly had a lot of examples throughout this pandemic about the toll quarantining has taken on, has happened to many people. As I said, older people tend to be more likely to use firearms. And the issue that we want to really acknowledge is that prevention is the key, whether we're talking about, suicidal thinking, or we're talking about passive suicidal thoughts, or we're talking about parasuicide, is that what we want to do is to prevent, older people from having to slip into a suicidal crisis. And so, what's the definition of prevention? Well, it's interventions occurring prior to the onset of a disorder that are intended to prevent or reduce risk of the disorder. Back in 1973, well, it was back in the early 70s when I started thinking about, how to create a telephone program that might provide access to people prior to slipping into a suicidal crisis. And as I think most of you kind of know, is that when we are interviewing an older person or speaking to an older person, if we start out by saying to them something like, I don't think you're going to be able to, live in your home safely because, you're getting older, and that's a lot of house for you now that your adult children have, moved out, and you might be there by yourself, or you and your husband are aging. And if we start out with that kind of discussion, older people are usually going to shut down because they perceive that to be a confrontation. And what we wanted to do with Friendship Line was to engage older people in a conversation rather than a confrontation. And so Friendship Line kind of falls in these two categories: prevention, as you know in the title of the Center for Elderly Suicide Prevention and Grief-Related Services, and interventions targeted to individuals who are a population subgroup whose risk of developing mental disorders is significantly higher than average. And that's where Friendship Line, kind of fits in, because we're interested in, targeting, older adults, caregivers of any age, and, adults with any kind of disabilities or mental health issues. And, the risk, might be imminent, for some populations of older people. We know people that have symptoms of borderline personality disorder are at increased risk of suicide. Uh, so that might be an imminent risk, or it might be a lifetime risk. And we're going to talk about that in terms of, trauma that, older adults who as children or preteens or teenagers had been the victim of, abuse, physical abuse or sexual abuse or other kinds of traumatic experiences, may be able to manage those experiences throughout their young adulthood and middle age. But when it comes to being older, oftentimes what they have pushed down, stuffed or repressed starts to seep to the surface as a person is aging. The other factor that comes up in terms of older people is something that Dr. Atul Gawande has written about in his book, Being Mortal, or in the film Being Mortal, that there are two unfixables, aging and dying. And there's not much we can do about that, despite, cosmetic surgery, despite, hair salons and, Botox and whatever. But as you can see, I skipped the part of the going to the hair salon and dyeing my hair. I'm just going to go as it is. But the idea is that there are a lot of obstacles to getting older in this society. And I often think that so many people are living in this Disneyland of aging, where we just want to be 40 for the next 40 years. And then at 80 or 90, that we'll just go to sleep and just never wake up. And that would be like a medical phenomenon if we were 40 for the next 40 or 50 years. And but the truth is that we age and we die, as Dr. Gawande has pointed out, and we need to think about that. As with many of you, I am, very involved in working with, older people, older clients, consumers, especially people that have experienced traumatic losses. And as so many of you discovered during this pandemic, that we had to be very creative in terms of how do we reach older people in our target communities or regions, and it's been a real challenge. And I talk to older people all day long, and whether it's on FaceTime, if they can use that format, or on Zoom. But I find that the majority of older people with whom I talk prefer to be on the phone. And so I call people quite a lot. And I was just thinking about, over this past year and a half, at some of the remarks that some of my consumers, clients have shared with me. And I wanted to share this excerpt, and it's kind of a combination of a couple different people, for, to protect their identity. And so this is a kind of an excerpt of a intervention with someone. And then the person, this was a female older woman, and she was saying, "Oh, Patrick, I feel like such a dope. I don't want to kill myself, but I'm thinking about it. And I'm thinking about it because the loneliness is so painful." And this woman lives alone. And she said, went on to say that the loneliness, the endless loneliness, is what's going to kill me. And I have no family here. I live alone, and I am grieving the loss of a family member who died several years ago. And I lack family. I don't have anybody in the area with whom to be connected. And I want desperately for family to love me. And then she just started crying. And this is a theme that I've heard, you know, well, probably since 1973, this type of thing. And of course, we can hear in there is that, you know, she's saying, I don't want to kill myself, but the loneliness is killing me. And so we know that she's, you know, thinking about this. And she's, you know, really wondering if she can make it through, you know, this pandemic, um, and by living alone. And so certainly what I want, and she does call the friendship line, which is very helpful, um, but she really needs to be connected. I want family, you know, I want to feel connected. I want family to love me. And you know, this is, you know, this kind of theme is just very heartbreaking. And what we want to do is to, you know, take her seriously. So, suicidal and parasuicidal behavior is a serious problem among the older adult population. The end result of both suicidal and parasuicidal behaviors can be death. So, even though parasuicidal thinking isn't as overt as I want to kill myself, and I have the wherewithal to do that, and that sort of thing. We call the behavior of trying to end one's life suicidal behavior, and we call the behavior of trying to harm yourself without actually wanting to die instrumental suicidal behaviors or parasuicidal behaviors. But it's really hard to distinguish, you know, to discern, is this person really at imminent risk of suicide? Or is this, you know, parasuicidal behavior, which is, you know, I may be thinking about death, I might be thinking about premature death, but I'm not imminently at risk of suicide. And we want to be, you know, thoughtful about that. You know, the study of suicide is very complicated. You know, we're accredited by the American Association of Suicidology, and we need, you know, to stay very current with, you know, practices that are evidence-based, that would be helpful for our volunteers to understand and implement when they're working with people on the friendship line. And, you know, some of you may have been to other trainings that I have done on suicide and suicide prevention. But again, I want to really emphasize the importance of prevention, you know, that 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 is something we all can attempt to do. And that doesn't mean that people won't die by suicide death. Sadly, we know that that happens. I wanted to mention, for example, in 2019, the data from suicide and self-inflicted death in the city and county of San Francisco. There was a total of 90 people in 2019 who died by suicide, and that was regardless of gender or race, ethnicity. And so there were 90 altogether. When it came to people over the age of 65, they accounted for about 25% of the total of 90 deaths by suicide in San Francisco in 2019. For people who were over the age of 65, who identified as Black, Hispanic, or Asian, or Pacific Islander, there were a total of 8 people in that category, and they represented about 9% of the total number of people over the age of 65 who died in 2019. And of the white population, there were 15 people over the age of 65 who died by suicide in 2019. So generally, the city and county of San Francisco, has anywhere between 110 people who might die of suicide death, and in this case, we had 90 people in 2019. What I'm concerned about, and I'm sure some of you are concerned about it as well, is that 2020 became a very hard year, and we don't yet have the official data on how many people died by suicide during that period of time. But nationally, people are concerned that that number, especially for vulnerable populations, people 45 to 64, or the elderly population, their numbers might increase in terms of death by suicide. And we'll have to see. But I think it's so critical that we're having this discussion today, because we're not done with the pandemic yet. And I think there's a lot of stress and challenges that we have yet to overcome. If you don't have a background in mental health, and I'm sure that many of you do not, you may not be able to, kind of easily distinguish between suicidal and parasuicidal behaviors. And so my suggestion is we want to take, every suicidal comment very seriously, even if it's veiled in something more passive, which is, I just don't see any reason why I should take these medications anymore. Or, I'm just, not going to eat, or whatever the comments are that are, an opening to something quite distressing that's going on. People who engage in parasuicidal behaviors typically have not developed the coping strategies to deal with distress, or the communication skills to express that they are in extreme pain, which might be both physical as well as emotional. I talk to many people who have severe arthritis, whether it's in their shoulder or their feet or their fingers or their, just hip joints, physical pain like that. We know with arthritis, there is no cure for that arthritic condition, although there are steps one can take to help reduce the pain. But to be in physical pain, coupled by emotional pain, can be, extraordinarily distressing. In some cases, individuals engage in cutting or self-harming behaviors to distract themselves from pain or a sense of nothingness, that, we often associate, cutting or, kind of mutilation of, the skin or arms by young people, but older people engage in that as well. And so they're really trying to communicate that, I'm in this space of nothingness. And I think by cutting myself or, scratching myself incessantly, that I'll feel something, to feel something, is so, it's so part of our human contract, being on this earth, that we are not only, intellectual, cognitive beings, but we're also emotional and spiritual beings and physical beings. And when we are in such pain that we just become numb through the aid of alcohol or whatever, it's a very, very dangerous place for humans, to be. And so again, I appreciate you all being here, just to, maybe get validated for what you are doing, maybe learning some, new ways of looking at older people or younger disabled individuals, that might be, a real life-saving opportunity for someone. you know, so, we're also looking at, as I said earlier, that, other people that might be in this parasuicidal kind of category might be using behaviors as a cry for help. Um, they might have taken an overdose of medications and followed it up with whiskey or other alcoholic beverages, and then they reach out for the phone, which is a very typical kind of parasuicidal behavior. So they might have been seriously thinking about suicide. They took these meds, they drank the alcohol, and then as they start to get woozy, there is a part of them that still wants to live, that still wants to be present. And so they reach for the phone or their cell phone and they call 911, or they call, someone close to them. But sadly, we know of numerous people over the years who have, taken drugs and alcohol and didn't realize that there wasn't going to be enough time to grab that cell phone, or they couldn't hold the cell phone in their hand, and then they died. And sometimes those types of deaths get recorded as a accidental death by suicide, rather than as the primary cause of death was suicide. If someone with parasuicidal thoughts engages in self-harming behavior and mortally injures themselves, they may die, even though their intention was to express a need for help or to try to counteract painful emotions. So what we have to discern is the cry for help within, thoughts of premature death and or suicidal thinking. We just have to be thoughtful about that. And it can be really challenging. And I just want to, emphasize just how hard it is to work with people who are not secure in terms of their place on the planet, and that they see death as a better option for the loneliness or the pain that they are in. So what we want to also pay attention to are, positive, protective factors, and that's what we believe here at Friendship Line, by reaching out to people on a regular basis who are vulnerable, or knowing that people can call in. We're hoping to have a group of staff who speak Spanish, so that we'll have an added component to Friendship Line, which would be a Spanish language Friendship Line. So we're trying to really reach as many people as we can. People often ask, well, do you speak other languages other than English on the Friendship Line? And we're always seeking volunteers, and any of you who are interested in volunteering, we would love to have you join our team. And we're especially interested in people who are bilingual, who come from other cultures or other ethnic backgrounds or sexual orientation. So we extend, an offer to all of you to join us. And we do have people on the lines who are able to be bilingual, maybe in Cantonese, Mandarin, Spanish. We do have some Russian speaking volunteers. And so we try our best then to connect a caller who may be more comfortable speaking in Mandarin with a Mandarin speaking volunteer. That takes a little while, but we would get back to them as soon as we can. But having this, what we mean by protective factors are characteristics at the biological, psychological, family, or community, including peers and culture on the community level, that is associated with a lower likelihood of injurious behaviors, or that reduces the negative impact of a risk factor. And what this reminds me of is that there are studies where people with high levels of connectedness, people that, as I'm sure probably most of you on this training today, prior to getting on the Zoom meeting, you might have been texting, family or friends. Like this morning, because of my aunt dying at 96, I had a number of phone calls with family members. And, so we have these connections, which might be with family, or it might be with, a senior center or San Francisco Village, or, other organizations, Institute on Aging, where you have, care providers who are reaching out to people or doing home visits. So, these factors really, really matter, and can really be the tool that people use to hold on to when life seems to be falling apart. Um, and then we have risk factors that also have a biological, psychological, family, community, or cultural level that precedes and is associated with a higher likelihood of injury or death. So where people stop going to the senior center, or they keep missing their doctor appointments. And now, since so many of those are on the Zoom platform, many of my older consumers or clients just don't even get on there. They don't even cancel it, because if they have a iPad or a laptop, they just don't feel comfortable or confident being on Zoom with their primary care physician. And so they just don't go to the doctors anymore. And those that are trying to get a neurologist, or trying to get to see a psychologist or a psychiatrist, the wait time, might be months before they can actually, be able to have an appointment to see someone. So that is a risk factor as well. And so people that have low connectedness feel often very distant from other people. They might describe themselves as more of a loner or an outsider. They will say things like, nobody understands me. I just want someone to listen. I want somebody to hear me. They have difficulty relating. They might have a lack of vocabulary to say that they are scared of dying, when the value that has meant so much to them was independence, autonomy, that they would always take care of themselves. And we know that as we age, things happen. People fall, and they break an ankle, or break their leg, or have a shoulder injury, and they need to connect with other people. But if they are people that have, they just have very few people with whom they connect, it's going to be a difficulty for them. And also, risk factor would be, as I mentioned earlier, childhood trauma that has never been processed. For those of you that have clients where they've had, trauma in their childhoods, and they are, connecting with you, you might want to consider, looking into a resource called Adult Children of Alcoholics or Dysfunctional Families, ACA. Might be something that they could find some comfort in terms of, meeting others who also had traumatic events in their childhood as well. Shame is another troubling experience that can cause a lot of problems for older people. Some of you might be familiar with Dr. Edwin Schneidman. Dr. Schneidman was really the father of the suicide prevention movement in the United States. He was the founder of the first professionally run suicide prevention center that began in Los Angeles, and the first volunteer based suicide Prevention Center was here in San Francisco. And Dr. Schneidman was also the co-founder of the American Association of Suicidology. And I went to as many talks as I could that he gave. And in one of them, he said that shame, rejection, a sense that it's not that I did a bad thing, it's the concept that I am a bad person, which he said is a way in which many people start to think about death by suicide, because they feel it's an indictment of their whole organism, that they are bad and they need to end that bad feeling by taking their own lives. And so although there are many services available, we know that every county has a crisis hotline or access to a hotline. We have the national hotline. We've got clergy that are knowledgeable in terms of offering support to vulnerable people, peer counselors, therapists, support groups. We have our, drop-in traumatic loss grief groups. To those experiencing thoughts of suicide, there are services available. But the decision to seek help can be influenced by a person's cultural background. So that's where we want to really kind of sit back and ponder this a little bit, is that, I think one of the most important aspects of working with people who are, thinking about suicide or not, is to try to help them figure out what prevents them from asking for help. Why is that so challenging? Here in the States, what gets in the way? And we need to be aware of people's backgrounds. Well, to that, most of you are probably familiar with the fact of disparities in mental health service use by racial, ethnic, minority groups, because it's pretty well documented that there is a lot of hesitancy by racial and ethnic individuals, and especially older people, to reach out to traditional mental health services. One thing Institute on Aging has done, that some of you, if you've come into the office here on Geary Boulevard, has seen we have a couple walls with pictures of the staff, and then little sayings underneath the pictures, and they're like, I don't know, 5x8 size. And the reason that we put this wall up, because we wanted to show visitors or people who are waiting to do an interview with our staff, that they might see a face that reflects their own. And I know many of you in organizations have tried various ways that we can communicate to people non-verbally or verbally, that we are a diverse staff that reflects the complexion of people in our communities. In combination with the findings that racial ethnic minorities tend to receive less overall mental health care, less outpatient mental health care, and are less likely to visit mental health specialists, suggests that older racial ethnic minority adults may not be receiving needed mental health services. And so that's what I meant earlier by, a lot of us might not have degrees in mental health, but what we have is a sincere desire to connect with people, and connections to others is what binds us to life. And so to me, if you have just an open heart and and compassion and caring in your speech, I think that you can go a long way to help change the trajectory from I'm isolated and alone to I feel connected. Rates of treatment initiation and adequacy indicate that the majority of older adults, regardless of race or ethnicity, are not receiving needed mental health care. Um, and we want to be, again, thoughtful about, what does our mental health system have to do? What do we have to do in terms of our, organizations, whether it's city and county agency or it's nonprofit? What do we need to do to be able to reach out effectively, to a diverse population of older people? And I think we have a ways to go with that. Um, uh, Doreen Marshall from the American Foundation for Suicide Prevention has said, just like there are cultural influences on one's view of physical health, there are cultural influences on how individuals might view their mental health distress. In African American and American Indian culture, environmental factors often increase the likelihood of suicidal behavior. Um, so even though, white individuals, are the highest frequency of individuals that die by suicide death, um, other groups also have death by suicide that they experience in their members. And we want to make sure that we are reaching out to everyone, and and we just have to stay humble in terms of culture, and to learn as much as we can when we are working with or talking with someone from a culture other than your own. In African American families, like values, family connections, expression through spirituality or music, reliance on community networks and church are enriching and can be great sources of strength and support. Another part of the shared experience is facing racism. Certainly, with books like Overground Railroad or Caste by Isabel Wilkerson. White fragility. There's a lot of opportunities for us to enrich our understanding of who we are in a multicultural world. Another part of this shared experience is facing racism, as I said, discrimination and inequity that can significantly affect a person's mental health. And I'm also thinking of, the LGBT, aging community. And the anguish that many people, prior to, the outrage that happened in New York at that bar in New York, where people finally said, we've taken enough attacks on who we are in terms of our, sexual orientation. And people started fighting back. So important that people before that date had suffered such indignities simply because they were gay or lesbian or bisexual or transgender. Being treated or perceived as less than because of the color of your skin can be stressful and traumatizing. And if people of color don't feel comfortable, or they don't see people who reflect themselves in the mirror, they may be more distrusting of of our services that we have available. As I said, the LGBT aging population is resilient, but at risk. Social isolation and victimization are major concerns for the older LGBT community. And we know transphobia is very cruel and intense, as homophobia is in general, and biphobia as well. LGBT family structures are not necessarily based on blood ties, and caregivers should be considerate of diverse familial relationships. And we know Open House and Unlock have been partnering to really be able to work with older LGBT members of both of those organizations. Uh, and then another form of suicide, as I mentioned, or suicide death, as I mentioned earlier, was passive suicide. And thoughts about death, itself can be appropriate for older people as they age. So this is where, again, it gets tricky with older people because, I mean, as I said, I'm 73 and I think about death quite a bit. I have a granddaughter now. My son and daughter-in-law had a baby during the pandemic and she turned 1 in July. And I was saying to a coworker here today that, because of just, my grandfather role with her, it just struck me so heavily that she's 1 and I'd like to be here when she's 21. And and I'm thinking about aging and death more than I've ever thought about before, and I think about it a lot just because of my work. Uh, and I'm, aware that, I'm not going to live forever, and impermanence is part of life. And I need to think about these things and talk about them because they are very relevant, to me in my 70 to 80 age corridor. Referred to as passive suicidal ideation, these types of thoughts are prevalent among older persons with depression or clinically significant depressive systems or symptoms. We know that one of the criteria for clinical depression is recurrent thoughts of death and or suicidal ideation. And yet, as we get older, we know we're a death denying, age denying, grief denying culture. And so how do we talk about death? And this is when we need to help people find a vocabulary for it. In a study done in 2016, it's estimated that between 11% and 19% of community dwelling older people report thoughts of death or death wishes. So, our aging colleagues or our aging peers, think about it. Of course, we're going to think about it, because we are getting older. Thoughts of death may be triggered by end of life issues due to other factors such as older age, loss of loved ones, or loss of health functioning. And as I had used that vignette earlier, is that I don't have family near me, and I need the love of family. And as we age, when family members die or disappear, and that can be extraordinarily painful for an older person to be the sole survivor of their, sibling, their siblings or other relatives. That can be really, really painful. Dr. Thomas Joyner, who is really advocated by the American Association of Suicidology. His father died a number of years ago, and Thomas then took it on himself to learn as much as he can about suicide and protective factors and risk factors. And his father had died in a van. He had driven to a remote part of the town in which he lived, and when and he had stabbed himself to death, which is a very painful way of dying. And he had left a note, and the note said something along the lines of, "Is this the way?" question mark. And so his son has tried to really find ways to help us understand better, suicide. And this theory proposes that an at-risk individual must have both the desire for suicide and the ability to carry out the act. And the desire for suicide is a thwarted sense of belongingness and a feeling of perceived burdensomeness. And I know that when I use that term, how many of you heard an older adult in your, that you work with, say, I just don't feel like I belong, or they say they feel like a burden, that can be very, very challenging. You know, the researcher Marty has argued that the interpersonal theory of suicide is well suited to describe late life suicide. Older people are more likely to experience shrinking social networks, which can enable a decreased sense of belongingness and dependence on others due to functional decline. And that would include increased burdensomeness. So when you hear older people saying, I don't feel like I belong or I'm a burden, a red flag needs to go off, and we need to think about that. Thomas Joyner also says there's no magical script that is absolutely fail-safe. So, you know, unfortunately, people do die by suicide death, but what we want to do is everything we can to help support them make a different choice. And I talked about compassion and caring earlier. The goal is to offer hope for the future and inspire willingness for the person in pain to ask for help. And I just want to go through some of these examples with us, and then we'll stop and see whether or not there are some questions that Catlin can open up in terms of the chat room. But I just wanted to offer these in terms of some of the things that we might say in response to a statement by a distressed person, which may not be the most effective. So when an older person says, I don't want to be here anymore, life doesn't seem worth living, if we respond, you don't mean that, or you don't really want to die, these comments reveal more about the helper's own anxiety or fear. And the message might be perceived by the distressed person as dismissive. If we respond to that same person in that example by saying, are you talking about killing yourself? You know, your life's not that bad. And I've heard people say that actually. Perhaps the outside, perhaps on the outside, the person in pain's life does not seem that bad to you, the helper, but the pain, however, is probably underneath, you know. And so we may wish to help the person in pain to explore that statement, which is, you know, I just don't see the need to continue. Another example would be an older person who says, I feel so depleted and tired, and I don't want to go on, and I don't want to die, and I don't want to go on. If we respond something like, you know, if the person is crying, we will try to stop them from crying by saying, please don't cry, you're going to be okay. And then we change the subject and say something like, what are your plans for today? You know, these statements, though I'm sure they're well intentioned, they just sound dismissive. You know, the person is saying, I don't want to go on. And then he repeats it again, I don't want to go on. You know, we're asking the person in distress to really silence their pain. And that's just going to increase this feeling that they have of, you know, aloneness. Nobody is there for me. You know, by statements like, please don't cry, or telling people they'll be okay, we're protecting ourselves because we sometimes just don't know what to do. You know, so we respond with, don't you know I would be devastated if you hurt yourself? That might be a family member, or a sibling might say that. You know, how could you think of hurting me like that? Well, the person in pain already feels awful. And, you know, that kind of comment serves only to increase their emotional pain. You know, we might respond to that same person by saying, but you have so much to live for. And, you know, how do we know that? They're saying, maybe I don't have much to live for. So for many people who think of suicide, they do not at all feel they have much to live for. This remark can convey a profound lack of understanding. When an older adult says something like, I am a burden to my family and friends, and if we respond, no, that's not true, and we often don't know their family. We may have never met their family, but we're going to say, make this assumption that, oh, your family loves you. Well, again, that, you know, our, you know, kind of this view a family through rose-colored glasses may be perceived by the older person who feels like a burden as they are being dismissed again. When an older person says, I just don't feel like I belong, if we respond, well, you know, you can go to a senior center, this referral misses the point. You know, the person says, I'm not feeling like I belong. And that's what we want to explore with them. And on a more positive note, and then we're going to go to Catlin in terms of questions. On a more positive note here, Linus and Snoopy are sitting on the dock of this, lake, and Linus says, someday we will all die, Snoopy. And Snoopy responds, true, but on all the other days, we will not. So that's the end of the presentation. I'm aware that I had a lot to get through there, and I hope you were able to follow along with me. And Catlin, can you
Yes,
share
hi,
some of
Patrick.
there are
Yes.
questions?
Actually, I'd like to go right to one that I see in the chat right now. I have other questions, but Sarah did ask if you could give a few more examples or appropriate responses for the examples that you just gave.
And one of the things that I've said, and some of you probably have heard me say this a million times, is that, there are 3 words that I think are crucial to working with, older people, especially, and or younger adults, is tell me more. Tell me more about that feeling that you have of being a burden to your family. Let them know that you want to understand. And I a lot of the suicide literature would say that even more than being loved, older adults have a intense desire to be understood. And so what I say to people is, I really, really want to understand, how you're feeling. I really want to know more about what you're thinking. Can you tell me more, about what's going on with you? And, and then we know if the person feels to you at imminent risk of suicide, then you need to ask the question, are you thinking about suicide? And, that is one of the big myths associated with suicide prevention, that there is thinking out there by some people that if you bring up suicide with an older person or a younger person, that's going to trigger a suicidal crisis for them. And that's a myth, is not true. And if you ask somebody, are you thinking about suicide? And you can say it just like I said it just now, without a lot of bells and whistles attached to it. What they're going to do is that they're going to answer. And generally, what I've found in these 48 years of doing this work is that older people are likely to say either, no, I'm not thinking about suicide, but I'm thinking about death and I want to talk about it. Or they'll say, I have been thinking about suicide. And then with either of those responses, what you want to do is keep the person talking, and this is where we want to remind people that there's a part of them that obviously is thinking about death, and we can, we're hearing that, so we can validate them. But what we also want to say, there's a part of you that wants to go on living because you're talking to me right now. That's the tip off, for us, that part of them that is still wanting to live has reached out, whether it's by the phone or by a text or whatever, and they're still alive. And what we want to do, and we do this through the friendship line, is offer transfusions of hope, not false hope that everything is going to be great, because obviously it's not. But what we want to say is that I'm here for you, or Friendship Line is here for you, or you can come to, um, this group, or do you have access to the Zoom, you know, or is it by telephone only? There's many things that we can do, but the most important that I would say is make a connection, you know, and when they say, oh, you have so many other people to talk to, you won't have time for me. What I say is, I'll find time, you know, we'll make time. Um, it's okay, you know. And when they say, but you have so much going on, and I say, right now, I'm with you. Um, and this is where we don't want to disconnect from them, um, until you can hear that they are a little bit better. What Dr. Schneidman would say, just a noticeable difference, just a noticeable difference. Uh, and you want to make sure you leave them with something. If you're on the phone, give them the number of, again, Friendship Line, or, other crisis lines in your area, wherever you live. Um, you know, Let them know that you want to talk to them again, you want to make another appointment. It's very important to do that, which is, if they are alone, you want to know if there's someone that they could call, do they have a family member in the area that they could call? Um, or I will say to them, let's make an appointment for tomorrow. That lady that I was talking about earlier, who was saying that, she, is just, the loneliness is killing her. I talk to her probably 4 times a week, and because she's really vulnerable. And so those are the things that you want to do. But the most important, I think, is to offer transfusions of hope, and you build on the part of them that reached out to you, or the part of them that said during an interview, I feel like a burden, or I feel like I can't go on, you know, um, and those kinds of phrases, especially "tell me more," says to them, I want to be connected with you. Tell me more. I want to understand. Tell me more. So that's how I would respond to that,
Right.
Catlin.
Well, and as you were saying before, Patrick, we don't know all the stats. One person said lately the numbers are anecdotally mostly higher, and they're known as undetermined causes. So it'll be interesting to see how these suicide numbers, these stats are viewed as the year goes on. When folks are socially isolated for long periods of time, says one person, they may express their loneliness and despair, but often seem even more resistant or suspicious of people when they offer help. They may express that they would be better off dead, but not really planning suicide. They don't want to eat, they don't want to get out of bed or bathe, saying they don't see the point, maybe stop going to the doctor, the dentist, just sort of suicide by neglect, self-neglect. How can we help those who seem to be at this stage? And the person who asked this question said the only thing that seemed to get her mother-in-law to stop talking like this was that she didn't want her grandchildren to see her in this state.
And see, right there is that connection,
Right.
that she has a connection to her grandchildren. And that's a very powerful bond. And that's one of the difficulties we've experienced in this pandemic, was that for a lot of older people, the only way they could connect with their grandchildren was through, like a Zoom platform or FaceTime or something, which, as many of you know, and I experienced this too, it wasn't the greatest, and then I have a lot of Zoom fatigue. And so it was, it just wasn't, the best for a lot of people. And yet it allowed them to see their grandchildren or see their adult children or other family members. And so I'm very grateful for the Zoom platform, but I'm also aware that, it is so not the same as face to face. And we need that type of connection. And, doctors, Carla Parasuicide and, others who have done a lot of work in terms of older people and loneliness and social isolation would say that, if somebody has been very lonely for quite a long time, that it can actually change the way in which our brain um, engages, other people. And just as you read there, Catlin, by the participant who offered that question, is that, you know, here we are helpers, and we want to reach out and support people, especially people who are lonely or isolated. And, they don't let us in, or they don't, follow up if we say, here's some referrals. Those of you who work for APS, you know exactly the pain of that. You know that somebody referred you to this individual because there's some problem there, and they will not let you in. Um, and that's really painful, I think, for us as helpers. But what I really urge is that when we are talking to somebody, be aware that that in that their brain has been affected by the loneliness, and they will become quite suspicious or skeptical about our reasons why we're reaching out to them. And I think what's important is, unless they say absolutely do not contact me, what I try to say quickly when I'm on the phone with someone like that is that I'll say, do you mind if I give you a call tomorrow? And the person will say, well, that's not going to make a difference. This is not going to be fixed by a phone call. I'll say, well, if you don't mind, I'll call you tomorrow at 1, and then I hang up. And then tomorrow I'll call them at 1, and they might say, Patrick, this doesn't do any good. Nothing's going to get better. And then I'll say, well, do you mind if I call you back tomorrow? And I'll say, well, it won't do any good. And then I say, I'll call you back tomorrow. And then I hang up, and then I call them tomorrow. And it might take numerous phone calls before that person who has been very lonely and isolated is able to say something like, yes, I need help. And for all of us helpers on this Zoom meeting, when they say that to us, it's like, hallelujah, there is an opening. The individual is willing, because there's a part of them that really does want to live, but they don't want to live in psychological or physical pain. Catlin?
Yeah, I have an interesting question here. Can parasuicide be a constant for people with PTSD? And is it possible to live with chronic don't want to live condition, either chemical or psychological depression?
Well, I think that's a very powerful question. And what we know is that humans can be extremely resilient under very dire situations, such as, we know this, right? Many older people we know have symptoms of depression, but they've been undiagnosed, unrecognized, and have lived probably the bulk of their lives being depressed, to some degree. Or we know this with the pandemic. I mean, people are so anxious. So many of my older clients are so anxious. And then when I say to them, maybe this is the time you want to talk to your primary care physician for a psych referral, maybe it would be helpful to have some medication that might be helpful to reduce your anxiety. And then they say, boom, no, I don't want that. I don't want any more medications, and then, and I respect that. And yet they continue to live, but they live in a world that is tainted by their anxiety, that is tainted by their depression, by disrupted sleep, by financial worries, or, physical health issues. And I think what can really be helpful to someone like that is just your patience, and your compassion, and your willingness to connect with them, and not try to, influence them you know, in any kind of way that would sound like badgering them. I think that we talk to lots and lots of people like this on the friendship line. We get 900 or 1,000 calls per day, and they are by people just like this person described. I wouldn't be surprised that that was a friendship line volunteer who asked that question. Catlin.
Well, we're heading into the 2 o'clock hour now, Patrick, and there are more questions. I could perhaps funnel those to you privately after, and we could answer some questions in an email when I send out the slides. But I would like to say that a few people have also expressed interest in learning how to volunteer for Friendship Line. So I can send along that information as well. Any final thoughts about that, Patrick?
I would say that just that last sentence that you said made my day. So anytime I hear the word volunteer interest, I'm like, oh, hey, this is well worth the effort that I put into preparing this presentation. And if I could just take one more second, I just wanted to end with this quote that I had read, Catlin, to you earlier. And this is written by Pat Conroy, the author of numerous books, including Beach Music. And he was writing about a man whose wife had died by suicide. And he wrote, "I could feel the tears within me, undiscovered and untouched in their inland sea. Those tears had been with me always. I thought that at birth, American men are allowed just as many tears as American women. But because we men are forbidden to shed them, we die long before women do, with our hearts exploding or our blood pressure rising or our livers eaten away by alcohol because that lake of grief inside us has no outlet. We men die because our faces were not watered enough." And, again, men are overly represented in the suicide death statistics, white men particularly. And so we really need to kind of, really look at our loved ones, our fathers, our husbands, our brothers, our sons, our nephews. And that doesn't mean to ignore, women, because women do die by suicide as well. But men far outnumber the women. And I think we need to find new ways to connect with people, especially men, especially, people of minority groups, older people. We need to do more work. And as Catlin said earlier, I am concerned too about what the official data in terms of suicide data is going to look like when it comes out sometime, in 2021 for the year 2020. I appreciate you all being here today. I'm sorry I can't see you in person. I would have much preferred that, as Catlin knows, but I think we made it okay, Catlin. So
We sure did.
thanks.
And we want to thank you for being with us.